All right. Well, it's good to see so many friends and colleagues here. This afternoon, we're going to enter into our first healthcare discussion, the quest for higher quality at more affordable cost. And that's the name of the session. That's probably the name of the next few years in health policy. I'm John Rother. I am now with the National Coalition on Healthcare, and our mission is to improve the value of healthcare, keep care affordable. With me today, we have an excellent panel. Friends and colleagues who are true leaders in this area, starting with Bob Berenson. Bob's at the Urban Institute today, but he's also the vice chair of MedPAC, and he's also had years of service in the executive branch with CMS and the White House. The second presenter is Sarah Thomas. Sarah is Vice President for Public Policy and Communications at NCQA, and I'm proud to say that Sarah was a colleague of mine for several years, several crucial years at AARP. She's also been the Deputy Director at MedPAC and other positions, CBO, and the full bios are in your packets. And finally, we have Brian Smedley. Brian is the Vice President and Director of the Health Policy Institute of the Joint Center for Political and Economic Studies. So a great lineup. I believe we'll have time for plenty of discussion and questions, and I hope that you'll have some questions ready when we wrap it up. Now, I am going to start off by trying to set the stage, and if I can get my clicker to work here, by talking about the challenge. And I think it's just worth taking a moment to see what's been happening in terms of on-budget costs for healthcare. And you can see that trajectory is pretty dramatic, whether or not you're looking at Medicare or Medicaid. And comparison to the rest of the budget, whether it's Social Security or discretionaries, is quite a gap. And so the cost pressure is really system-wide cost pressure in healthcare, not particular to any of the programs themselves. When we look at what this means for people, this is getting serious. Rising costs are affecting net take-home pay for most Americans. The projected increase could well outpace any increases in productivity or overall wage gains. So we are giving up every resource we have to improve standard of living to health care at the moment unless things change. Now, the story is much the same in the private sector as well as the public. I hope you can read this. We're up to about $15,000 per capita for workers with health insurance, and the trend is much the same as with Medicare and Medicaid. So it's a system-wide phenomenon. We cannot just change Medicare and expect the rest of the healthcare system to become more efficient. When we look at the trend lines for Medicare versus private insurance, maybe some of you might be surprised. Medicare doesn't look that bad compared to what's been happening in private insurance. But I think that really the overall point is that regardless of which you're on the blue line or the red line, neither one is a good direction. We've got to figure out some way to stabilize these costs and get higher value for our money. Now, one thing that I'm especially sensitive to is not only the overall cost, but the burden that out-of-pocket costs impose on family budgets. And here, I think the story isn't so much the average as it is the cost in the sickest part of the population or the lowest income part of the population. And now we are looking at truly extraordinary out-of-pocket costs for low-income Americans and those with chronic illnesses, to the point where I really don't think we can talk about increasing the so-called skin in the game when people are spending so much already out of their limited resources. When we look at Medicare as part of a budget, which is, I'm afraid, the way the debate's going to be framed this year, you can see it's no surprise we're over 17% now, and the trend lines are ever growing. And so I do believe that a year from now, there's likely to be a very serious deficit reduction effort targeted at health care programs. So I think we as a community have about a year to figure out how we're going to deal with this. And if there are ways we can suggest to keep care affordable that also improve quality, improve outcomes. And let's see, I think I have one more. Yeah, here we go. This is the figures for Medicare beneficiaries, again with out-of-pocket costs being very highly concentrated in the top quintile, almost $8,000 a year out of pocket. And finally, a focus on the group that I think is the least well understood, least well managed group, the dual eligibles, those who are Medicare and Medicaid, and they account for a disproportionate share of health spending. They are often not experiencing very well coordinated care, and there are many disabled Americans as well as poor Americans and nursing home residents in this group. So it's a very diverse group. And again, large numbers of dollars devoted to the duals in both programs, both Medicare and Medicaid. And then finally, the issue of waste. A lot of people are taking estimates on waste. I think one of the most authoritative was an Institute of Medicine study that I was actually part of that concluded that about 30% of our healthcare dollar does not improve health, and that's unnecessary. There's no one silver bullet. As you can see, there are many areas that contribute to waste, but I think the larger point is 30% of our healthcare dollars are potentially the object of reforms that, if we can save here, would not affect patient care. So that's the opportunity as well as the need. And with that, I'm going to turn to our first speaker, Bob Berenson.
What have you done to me? Okay, thank you. It's a pleasure to be here. And first, I need to do a disclaimer. John told you that I'm on MedPAC. For those who don't know exactly what MedPAC is, it's not a political action committee of doctors. Some of the relatives who I've told that I'm on MedPAC, that's what they assumed. And now, MedPAC is the Medicare Payment Advisory Commission, which has been in existence since 1997 as an advisory body to the Congress on Medicare payment and related policy. It's an independent commission. I am not here speaking on behalf of MedPAC. I don't think anything I say is contradictory to MedPAC policy, and indeed in a couple of places I'll be using some MedPAC information, but I'm not here speaking on behalf of MedPAC, just to make that clear. Let me start with some initial observations. I'm going to be focusing on the issue of quality at lower cost, the role of Medicare, which I'm sure everybody in this room is interested in. John made the point just now that we need overall health system reform, and if we actually do that, there will likely be improved quality and value, lower cost in Medicare. But I'm going to argue that there's also a major role for Medicare in taking a lead in producing health system change and also taking care of its own, in a sense, its own laundry. And I'm going to start with some initial observations. First, that overall delivery system change often occurs as a result of basic Medicare payment and related policies. Medicare actually back in 1992 adopted a new way of paying doctors called the resource-based relative value scale based fee schedule. That approach has now been adopted by virtually every private insurer, and for good or for bad, it's got some good points, but it is contributing to a continued distortion of payment prices that rewards specialists in high tech and under rewards primary care and low tech. It comes out of the Medicare fee schedule. Right now, every hospital wants to employ a cardiologist, and indeed there's been a massive migration of cardiologists from private practice to become hospital employees. It all has to do, not all, but the major stimulus is Medicare policy on how they're paying cardiologists for particular services and differential payments to a hospital versus physicians in a private practice. It's, I think, understandable that hospice is a very Medicare concentrated service. Older people take advantage of services around death and dying more so than younger people. It is an excellent benefit. It is a Medicare benefit. It has also spawned a for-profit hospice industry in general. I have nothing against for-profit industries in healthcare. There's something unique going on with the hospice industry. It's a Medicare service. It's a Medicare problem. Let me go to the next observation. And that is when we talk about value, that quality reporting, which I assume Sarah is going to be talking about, and pay for performance, which just as an education it has arrived in healthcare, are about how well professionals, providers perform what they set out to do. How well are they taking care of diabetics? Are the diabetics' blood sugars and management under control? Are they seeing ophthalmologists when they're supposed to? But it doesn't spend a lot of time worrying about, at least in the current iteration, about whether we're providing the right mix of services for the population served. So I would argue that value-based purchasing, achieving higher value, is as much about incentives, organization, culture in those organizations as about specifically measuring quality and cost. And a specific example I alluded to earlier, which is if we wanted a higher value health system, we would produce a different mix of clinicians, more orientation to primary care and to coordinating teams for people with multiple chronic conditions and frailty and disabilities, and have a little less of an emphasis on high tech. Some of you may have heard about accountable care organizations. That has received a lot of recent attention as a potential game changer. These would be organizations of providers, sometimes hospital-based, sometimes just physician organizations that would be given financial incentives and be assessed for their quality and cost. So even without a health plan involvement, in the case of Medicare, it would be direct contracting to these provider groups who would be incentivized to produce higher quality at lower cost and be measured for it. My own view is that this is absolutely potentially a game changer in the long run, but it will take many years. It still needs a proof of concept, and that we need to be doing other things. There is the Center for Medicare and Medicaid Innovation. The legislation calls it CMI. The Centers for Medicare and Medicaid Services calls it CMMI, not to leave out what some assume is Medicaid, but so it's CMMI. They are putting all sorts of demonstrations and projects to try to develop new models of care. I think they're actually moving perhaps too quickly. I disagree a little bit with John. I actually think we have more than a year, that we have 5 to 10 years to get this all right, or to get new models of care and new organizations standards of care because we have some other ways to hold down spending in the short term. What people I don't think have understood is that with the changes in the Affordable Care Act that reduce payment to providers, mostly hospitals but some others, and with a slowdown in the volume and intensity of services, per capita spending in the Medicare program is really going up no faster than GDP. It's about at its best rate of increase that it's been in decades, well actually since the founding of the program. That takes some of the immediate pressure off the program, and I'm going to continue that theme in my next set of slides. So my question is, does the clear need for broad delivery system reform preclude Medicare-only actions? There's some concerns about Medicare acting too strongly on its own. One concern is cost shifting. Medicare holds down spending, and hospitals turn around and raise their prices to private insurers so that somebody else is paying the bill. There's a concern about second-class care, that if Medicare holds down spending too much, that Medicare beneficiaries will be treated as second-class citizens. There's a concern about Medicare overusing its market power as a major single payer, government payer who can set prices, and that they might be paying lower than marginal cost and really underfunding providers. Those are all concerns, but again, I would argue that value-based purchasing inherently involves balancing these issues, cost, access, and quality. You can't just ratchet down on prices because access would suffer. And so I would point people to this thing called the SGR, but it's known more in the popular press as the doc fix. On the books, physicians are supposed to receive a 30% reduction in their fee schedule because of a decision made in the Balanced Budget Act in 1997, which still hasn't been overturned. It doesn't ever happen for the very reason that we know that access and quality would suffer. So the Congress every year, sometimes 3 or 4 or 5 times a year, postpones this thing from happening. There's sort of a natural dynamic, I think, in between the politics of the Congress as well as what we talk about on MedPAC to try to balance cost containment, quality, access, et cetera. Yeah, okay. Now, I agree that public and private payers share common interests, and in fact, that's what I think the real potential is going forward, is that private payers and Medicare can actually get together in a number of areas. I've suggested a couple on the slide, and there's actually under the Innovation Center some demonstrations going on now, which is a major challenge. It's having Medicare, CMS sitting at the same table with private payers and Medicaid agencies to come up with common programs. That's an important part of the demonstrations. Old-fashioned payment updates affect the delivery system as well. I'm not going to go through the next 2 slides in much detail. The point of this, I'm actually going to go to the next slide and make the following point, that what we know is that undisciplined spending by many hospitals produces negative Medicare margins. It looks like hospitals are losing money on Medicare. But efficient hospitals, this comes out of MedPAC work, efficient hospitals, those without the ability to generate high prices from private payers, have lower costs, relatively high quality as we measure it, and break even or do better on Medicare. So payers, including Medicare, can set rates of modestly aggressively to try to put pressure on costs. The single major reason why U.S. spending is more than in other countries is the high prices we pay to physicians, hospitals, other providers in relationship to other countries. Now, it is not so easy for other commercial insurers to put pressure on prices because of consolidation in the provider space, I guess we would call it. This is based on research that I've been involved with at the Center for Studying Health System Change. Providers are consolidating into all sorts of different kinds of organizations. The era of the small individual solo doc, the independent hospital is coming to an end. We have larger aggregations that may improve quality, but one of the side effects of that is in negotiating with health plans over prices, it gives them much more clout. to get high prices, and that is a major driver of health costs in the system, is high prices that providers demand in these negotiations. It is not purely a function of consolidation. There are other factors here, one of which is reputation, another which is geography. So it leads to the following quote from somebody I interviewed. We have clout not because of our size, but who we are. Am I supposed to apologize for that? It's a famous hospital that gets payment rates that are very high, and they think in a competitive health system that their reputation permits them to get those rates. We don't have a basis for, or health plans don't have an ability to counter that at this point. So there's some policy implications. Providers think that health reform, whatever that is, will change these contracting dynamics, but don't know exactly when and how that will happen. And many of these hospitals and physician groups are pretty confident that they will continue to be able to get high rates from private payers. Even we expect more integration. That seems to be the name of the game in health delivery now, is consolidation, docs and hospitals getting together. For reasons I could get into if anybody's interested, there's not much of a role for antitrust policy here. So that does invite the question of should we rediscover state-based rate regulation as an intervention. The state of Maryland still has a program from the 70s which regulates private rates, and so I'm suggesting that that may be something that we're going to have as a public policy discussion, at least in some states that would see a role for government here. Let me finish up in the next 2 minutes with just a couple of other points about why Medicare can act on its own in a couple of specific areas. There are some areas within Medicare, not the docs and hospitals who I've just talked about, that are particularly high drivers of spending and geographic variation. Home health, durable medical equipment, hospice. I want to go to the next slide right here. This is an example of durable medical equipment spending variation in South Florida. It basically shows that Miami-Dade spends 10 times more per person than in Collier County. Miami-Dade is unique in a number of ways, but this is an example. I'm sure you all remember Atul Gawande's article in the New Yorker about McAllen, Texas. It was an important article for the president, and everybody in the administration had to read it. Well, it turns out that in an article in 1993 that I wrote, I referred to McAllen, Texas, and then this guy Gawande comes along and gets the credit. The point I made in the article is if you just look at the data, the most recent data was something called the Dartmouth Atlas from 1998 at the time. It turns out that McAllen, Texas spent 10 times more per capita on home health services than the average across the country. It represents about half of the spending increase in McAllen, Texas. There are special problems that Medicare has that it needs to take care of. One final example, and then I'm going to end. Hospice. I made reference to this earlier. The national average of decedents, those Medicare beneficiaries who experience hospice before they die, is 39. And in Mississippi and Iowa, it's not that different from that. But in Mississippi, 55% of Medicare beneficiaries in hospice are actually discharged alive from hospice. They also have extraordinarily long lengths of stay. Hospice is supposed to be a program for people who a physician thinks are likely to die within 6 months. 55%. This program is not being used as intended in Mississippi and actually in a number of other states. So that basically says that Medicare's got some special fraud and abuse problems, and this is my point, that I think Medicare, if allowed to, if CMS, the administrator of Medicare, were allowed to, costs could be held down for a number of years while we are trying to figure out how to really do this delivery system reform and figure out how to fundamentally change the payment incentives, the organization, and the organizational cultures. And with that, I will stop. Thank you very much.
Hi. Now let me see if I get this right. So great to be here. Thank you for inviting me. And I wanted to stop quickly in case people haven't heard of NCQA. I think even less famous than MedPAC. So NCQA is a nonprofit organization. We got started with an accreditation program for health plans, and we've gone on to be one of the big developers of quality measures for health plans and other providers. We have other evaluation programs, which I'll talk about today also. And we've also gotten to be quite a substantial government contractor developing quality measures for the government. So we really come from a private sector history, but we've actually more and more done work for the public sector as well. And that's going to be the focus of my short presentation, to really talk about how the private sector and Medicare and Medicaid programs have aligned, and how that can really create some synergy to really move the dial on value, not just quality. So some key points I wanted to make before I even get started, because I always like to hit the punchline. First of all, these transparency initiatives and value-based purchasing are very common among payers. And you really see, in some cases, they start with the public programs. Sometimes they start with the private ones. Rarely do they actually start together, but actually there's some examples where private payers and Medicaid programs have gotten together that I'll talk about. Medicare has really unique leverage and data, and I think it's pretty exciting with the Innovation Center to see that it's beginning to use that. But of course, it faces political constraints in fully exercising that purchasing power. Alignment can move the initiatives forward, and even though we've seen tremendous improvements in quality over time, we're a little bit in the doldrums, and we've seen a little bit of flattening. And I'm actually quite excited to see a huge amount of interest in quality again from the Medicare perspective, as the Medicare Advantage program is going to a pay-for-performance system around the very same measures that have been kind of flattening out. So I think Peggy O'Kane, our president, and I find this conceptual framework quite helpful. So this is a pie chart that comes from analysis that John Wemberg has done of Medicare claims. And he's divided the claims into 3 different categories. The red slice is care that is really effective care. And I'm sorry, is it red? Okay. There's not much of the care in the healthcare system that is really known to be effective. That's partly because we just don't have enough knowledge about what care is being provided that's effective and what isn't. The biggest slice is supply-sensitive care, which you see more of when you see more doctors and hospitals. And the last slice is what he calls preference-sensitive care, where there are 2 equally good choices, and it really depends on the patient about what they think is going to be the best care that suits them. So for each of these kinds of care that you see, there are actually different policy levers. So I think in the area of effective care, what we need to do is get more of that. The HEDIS measures that we've developed are really intended to get people providing more of what's known to be effective in that quadrant. And transparency initiatives, pay for performance with these measures, I think is all targeted in that direction. The supply-sensitive care, that's where you're getting into the delivery system reform. And patient-centered medical homes and ACOs, what they're really trying to do is change payment incentives and align incentives to be more prudent in the use of resources. And then in the last quadrant, I'm not going to spend as much time on that, but there are really exciting tools in benefit design and shared decision-making where you can engage patients to really understand what they want, and that can actually end up resulting in care that's better value and lower cost. So I'm going to start sort of using another cut, which is to start with thinking about health plans. Now, health plans are the most convenient accountable entity. And if you think about the old days of health policy, we all thought health plans were really where all the action was. And we actually have seen a lot of improvement in care provided if we look at health plans as a unit of analysis. So this is a chart that shows several of our HEDIS measures. These are for commercial payers, and HEDIS is a measure set. It's a common measure set. We get into excruciating detail about how each of these measures are defined into codes and what's included and what's excluded, numerators and denominators. And it started by a number of health plans coming to us and say, help. All these different employers are out here, and this employer asked for this set and this one, and can't we come up with a common measure set? And so that's what HEDIS is. It's a common measure set. We started with process measures. We've gone on to include more measures of outcomes, and I'm going to talk in a minute about some of our cost measures that we're including in the set. It started as a private initiative, but now you see HEDIS measures being used in both Medicare and Medicaid. And in fact, I would say that Medicare's gone above and beyond to include it in the star rating system, which is going to be the basis for payment I'll talk about too. The bottom measure, that going down is lower is better, so that's the success story. But I would also point out that even though the overall pattern has been upward or downward in the case of that measure, that's kind of flattening out. So I think that, transparency is great. It's a great first step, but I think we could probably bring more incentives to bear. And actually, the whole area of exchanges is another opportunity to bring more covered lives, more incentives around pushing this slope up for these kinds of measures. So I'm going to give you a little bit of information. This is a little bit complicated, so I'll try not to go too fast. But about we realized that really value is not just about quality. And the public purchasers that we work with have become less and less interested in quality by itself, and more interested in just the problem of the cost of care. So in response to that, we have developed what we call the relative resource use measures. And what these are is they are aggregate spending within clinical categories that you can use to compare with quality. So they are the categories that you can see here are diabetes, asthma, COPD, cardiac care, hypertension, and low back pain. And what we do is for each health plan, again, that's the unit of analysis, we can actually map out how much they're spending for patients with these conditions compared with how much the quality of care is for these conditions. And you can see the northwest quadrant is health plans that have high quality and low resource use. And the ones in the southeast quadrant, not by design, but it's just turned out the southeast has been a higher cost or higher resource use and lower quality. That actually is not that unlike what we see when we look at a geographic map of the country. So it's actually a powerful tool for purchasers to begin to say, you have high quality, but it takes you more resources to get there, whereas another plan doesn't. This is an area of waste. So it's another tool for looking at the kinds of opportunities for waste that the other speakers have talked about. We can actually drill down with these in excruciating detail. I won't spend a lot of time, but we can actually look in categories, and you can see that in this chart, you can see Plan D is higher than average on quality, so it's got an index above 1, and it's able to deliver care at lower than average resource use, and this is for people with diabetes. So you can begin as a purchaser to sit down with health plans and say, hey, one plan is doing better than another, and it can be a force for negotiation. And I'd like to say that this tool is being used in the Evaluate system, which is a uniform RFP for employers. Okay, just coming back to this issue of moving the quality line upwards. I think the Medicare Advantage star rating system is a great opportunity. And this is a great example where there's a private initiative that came up with measures. Medicare started reporting, and now Medicare is going beyond the private sector to include a very exciting pay-for-performance system. And by exciting, I mean that people have started inviting me to conferences to say, how can we boost our star ratings, which I think is a great example of incentives fulfilling. And it's too early to see in the data whether that line's gone up, but just the level of interest. So vendors are out there saying, we can boost your star rating system. This is your key to success, and that's great. I mean, it's wonderful to hear health plans caring about improving their quality. So I won't go into the details, but I think it would be very exciting in the world of health insurance exchanges to see systems like this that reward health plans that do better on quality. And we actually have a whole agenda. Am I losing volume? I'm okay. For health insurance exchanges, I won't go through all of this in great detail, but we really see health insurance exchanges as a great opportunity as new people come into the insurance market to really capitalize on this. This is, these are government subsidies that are coming in, and these are folks that have never, been really captured in a lot of our metrics, and it's a great opportunity to capitalize on this. And so we have sort of 4 categories of things we'd like exchanges to do. The first being setting up report cards that actually highlight health plans that are both high quality and low cost. I think a lot of these report cards have really driven people to the premium, and I think that people need to think beyond the premium to the cost sharing and also to quality, and that should be the first plan they see. Now, you may want a very small number of choices to really help structure choice, but at least you want to filter the system so that you get the best plans come up first when you go onto the website. I think there are benefit designs that we like to see that emphasize high-value care, network design that rewards high-quality providers, and really see health plans not just be the averagers, but to really actively trying to sponsor delivery system reform. So I will jump over the summary and get right into delivery system reforms. So one of the most exciting experiences I've had is in the last 2 years in NCQA is seeing this line go up of the number of practices who are recognized as patient-centered medical homes. This is an evaluation program where very small practices come forward to be recognized in providing high-quality primary care, coordinated care for their patients. They provide care in teams. It's really a lot of the recipe for success that many people have said this is the way that we need to provide better quality care in primary care. We've seen an enormous amount of interest in it. I would say this is an example of an initiative that started on the private side, but in many cases it was a combination of employers and Medicaid programs that really got things off and running. Medicare is a little bit late to the party. Medicare is finally at the party, and they are going to be matching some of the incentives that are being paid, but it's great to see that this is an area where there's a lot of alignment, and we're beginning, much to my great pleasure, to see some success stories. It tends to be a program that works best where there's a scale, enough of a scale, and where there's actually support provided for care coordination at the practice level. So the first of those is an example from the Medicaid programs and was published in Health Affairs last summer, and it's very exciting to see some of these results. We are also very interested in the potential of the ACO program. I would say this is a program that's really starting more on the Medicare side, and it's early days. I think Bob's mentioned some of the concerns that we also share about its potential. I think this is a program where there could be more private and public alignment. Right now, this is really a Medicare show, and there's a few private payers that are out there trying this out, but they're worried about the very same issues with too much purchasing power or too much supplier power on the provider side if you form these ACOs. So I think what we are trying to do is create an evaluation program that, like the patient-centered medical home, creates sort of a common platform so that everybody knows what an ACO is just as now everyone knows what a patient-centered medical home is. This is sort of some elements of our program. I'm not going to get into the details there. To summarize, I think we're making a lot of headway in primary care, but we have a lot of room to grow in the specialty care, and that whole analysis of high value and low cost. If you look at the detail, you actually see a lot of the drivers of the higher resource use being readmissions. This is a huge area for opportunity and getting at better value. I would also say that it is harder with the delivery system to build these accountability frameworks in there because the unit of analysis is often small, small practice. It's hard to get good measures for it, but we're working on it. And finally, I think that, like others have said, I don't think this is an either-or. I think that we need to get both initiatives targeted at health plans and at the delivery system and across all these different payers to really get the greatest synergies. So thanks.
Well, good afternoon. I want to thank the conference organizers for arranging this wonderful panel. I think the challenges around costs and quality are obvious. I'm going to take us outside of healthcare financing and delivery far upstream, so much so that about halfway through, many of you will be saying, what in God's name is he talking about? And what does he want me to do about it? So, but I hope to convince you that the approach that Sarah has suggested, that it's not either or, that there are a comprehensive array of strategies that we need to begin to employ. This is critically important because the challenges around costs and quality are enormous, and so much so that it becomes impossible to conceive of a magic bullet to address these challenges. I'm going to talk about the need to address community-based primary prevention. This is an issue that's obvious to most of you, but I think when we reflect on the fact that I believe this is still true, for every dollar of federal health care expenditure, about 5 cents goes to prevention. And so clearly when we see the kinds of patterns that we've seen today, the need to address who gets sick and who is well in the first place becomes imperative. We're not going to address many of these cost challenges unless we ensure that we have a population that is not so burdened with illness and disability and disease that our healthcare systems are overwhelmed. So that's the first thing, community-based primary prevention. The second issue is one that we rarely talk about, but we're challenged to address it, and that is we have an enormous demographic change happening in the United States, a tremendous demographic change happening. This is a very different nation than what it was even 10, 20 years ago. 40% of our young people under 17 are people of color. Today, over half of the babies that are born in the United States are babies of color. And yet, as most of you know, many communities of color are disproportionately burdened with disease, disability, premature death. Literally from the cradle to the grave, we see higher burdens of disease and disability and premature mortality among many communities of color. So addressing this challenge of disparities, or inequities as I'll call them, becomes imperative because many of these patterns are in fact socially produced. They're not naturally occurring. It is not naturally a natural phenomenon to see some population groups disproportionately burdened with disease and illness. As I hope to convince you, they are socially produced, and so we're challenged to think even well ahead of healthcare financing and delivery about strategies to begin to address some of these problems. I want to talk a bit about the economic consequences associated with health inequalities to make the connection that these are not special interest issues. These are issues that deeply affect all of us. And indeed, any of us who pay a health insurance premium are paying higher rates in part because, again, systematically some populations face a higher burden of disease and illness. This is from a study that my organization, the Joint Center for Political and Economic Studies, released 2 years ago. In fact, here at the Press Club, called The Economic Burden of Health Inequalities in the United States. If it is true that some populations have a higher burden of disease and disability, premature mortality, then what is the economic cost for the nation associated with this problem? So we attempted to estimate this economic cost estimating both the direct medical costs associated with that higher burden of disease and illness. In other words, how much more are we paying because some populations are systematically less healthy? What are the indirect costs associated with health inequalities? In other words, because some people are too sick to work, what's the cost to the nation in terms of lost productivity, lost wages for breadwinners? And for those families that suffer from the loss of a breadwinner, a loss of a loved one, prior to their working years being over, then there's certainly a cost not only to those families, but also to society. We lose local, state, and federal tax revenue when people die prior to their productive years of life being over. What we found was very striking. Using MEPS data, Medical Expenditure Panel Survey data, we estimated direct medical costs in that 4-year period between 2003 and 2006 as being 30%, over 30% of the direct healthcare costs for African Americans, Latinos, and Asian Americans. And in that 3-year period, that total cost came to nearly $230 billion. These are excess costs due to that higher burden of disease and disability in these communities. When we add in the indirect costs associated with lost wages and productivity when people are too sick to work, lost tax revenue, et cetera, the total tab came to $1.24 trillion in that 4-year period. Now, some may argue these numbers. The Urban Institute actually came out with a similar study looking at a narrower range of diseases, but similarly found a very high price tag associated with these health inequalities. So the issue here is that these are problems that affect all of us. And again, for all of us who pay a health insurance premium, we help pay for some of these costs. It's also true that there's a growing body of evidence showing that prevention, particularly community-based primary prevention, intervening at the level of communities, can help save us money on the back end. There's a significant return on investment. One of the most important studies in this body of work came out again in 2009 from the Trust for America's Health and the Prevention Institute. They estimated that an investment of as little as $10 per person over 5 years can save us as much as $16 after 5 years and nearly $18 billion annually 10 to 20 years after these programs are implemented. So more work needs to be done here, but the suggestion is that as we invest more in prevention and in helping people to make a healthy choice, creating conditions that allow us to achieve our best level of health, then again we have a reduced burden of disease and disability for society at large. Part of the work that we focus on at the Joint Center is on the role of segregation. And here's the part where you're going to be saying, what does he expect me to do about this? The challenge here is to understand how we organize our society and structures and systems that systematically create patterns of ill health among some populations and patterns of relatively good health among other populations. We tend to think of segregation as being a relic of our past in the United States, and certainly we've made a lot of progress. Since the 40s and 50s, there are no longer Jim Crow laws on the books. Most of our communities, we see integrated pockets of communities, but in fact, segregation persists at high levels in many American cities and even small towns. The problem with segregation, as I hope to show, is that it systematically shapes who is healthy. We know from a large body of research that segregation concentrates poverty. It tends to exclude and isolate people of color, those who are in these communities, from mainstream resources needed for socioeconomic advancement. And all of you know that there's a very important and positive relationship between socioeconomic status and health status. It's the socioeconomic status health gradient. At each step up the socioeconomic ladder, our health tends to get better. At each declining step, our health tends to get worse. So when people are systematically in communities that lack access to structures and systems that advance socioeconomic mobility, then their health suffers as well. We know that many of these communities have poor quality schools, schools with crumbling facilities, inadequate and outdated textbooks, teachers who are not credentialed to teach in the subjects that they teach in, fewer job opportunities, lower access to capital to start businesses, and even more important when we think about this wealth divide, lower returns on real estate in segregated communities. And all of you know this. This is why real estate agents say location, location, location. So in every American city, in a majority white community, you can take a 3-bedroom home identical to one in a segregated community, and the one in the segregated community has a lower value. It will appreciate less over time, and there's less wealth passed along to the descendants of those families that live in that segregated community. And again, it has important health consequences because of that health-wealth relationship. We know that in many segregated communities, the people who live in those communities have lower access to health-enhancing resources, things like grocery stores. We know that African Americans are 5 times less likely than whites to live in a census tract with a grocery store selling fresh fruits and vegetables. In contrast, in many of these communities, what we find is that the retail food environment is saturated with fast food, carry-out stores, tobacco vendors, alcohol vendors, people selling things that are bad for you, overexposure to bad products. My hometown of Detroit, Michigan is one such example. For many years in the early 2000s, late 1990s, there was not a single major grocery store or supermarket within the city limits of Detroit, making it geographically impossible for people who did not have reliable personal transportation to access healthy foods and fruits and vegetables. Similarly, in many of these communities, there is a relative lack of parks, green spaces, safe places for active living, recreation, etc. So we tell people, eat your fresh fruits and vegetables. We tell people, exercise 30 minutes a day. In some communities, this is easier said than done. In the United States, of course, we place a high premium on individual responsibility, and that's important. We are responsible for our behavior. We must take on healthier behaviors, but it is often very difficult to preach to folks who live in communities that are overrun with health risks to adopt these kinds of health-enhancing behaviors. We know that many of these communities are overrun with environmental health hazards, disproportionately exposed to polluting industries, sources of air, water, and soil pollution. We know, for example, from a major study by the United Church of Christ that replicated a study that they did 20 years earlier. The study was released in 2007, that 56% of people who live in communities with hazardous commercial waste facilities are people of color, yet they are only about 1/3 of the U.S. population. And then there's the poverty tax. People who live in these communities often have to pay more for the same basic goods and services as people in more advantaged communities. So you pay more for auto insurance. You pay more for bank fees if you can find a bank. In many of these communities, you cannot find a bank branch, so they are unbanked. What you have in contrast are check cashing outlets that take a big chunk out of the paycheck in return for cash. So these are the kinds of structural obstacles to socioeconomic advancement and good health faced in many of these communities. The problem in the U.S. is that many major U.S. cities remain highly segregated and unfortunately have not advanced in terms of desegregating as much as we might expect. These are data from demographers such as Doug Massey and others using a measure called the dissimilarity index, which is the percentage of people in a defined geographic area who would have to move to create integration between 2 population groups. So in South Africa in 1991, prior to the dismantling of apartheid, the country had a dissimilarity index of 90, meaning that 90% of white and black South Africans would need to move to create integration in that country. And unfortunately, several major U.S. cities, as late as 2010, I need to update these data, were not far behind the level of segregation found in South Africa. In Detroit in 2001, the dissimilarity index was 85, meaning that 85% of white and black Detroiters would need to move. In 2009, the dissimilarity index was 86, so we're not making progress there. Several other major U.S. cities are not far behind, Milwaukee, New York, Chicago, Newark. All of these cities had dissimilarity indices of 80 or higher, meaning that 4 out of every 5 individuals in those cities would need to move to create integration in those communities. Just a few months ago, we released a report called Segregated Spaces, Risky Places, looking at the relationship between the level of segregation in a metropolitan area and several health indices, including infant mortality. What we found was quite striking, that despite the fact that levels of residential segregation have declined slightly between 2000 and 2010, these levels of segregation remain high and remain a significant predictor of the magnitude of the health gap between Latinos and whites and blacks and whites. So much so that when we simulated having the level of segregation down to 0, that is when the dissimilarity index is 0, we found that we could have saved as many as 2,800 African American lives in the year 2008. So what can we do about this problem? And here's where we tie in to what's happening today. The Affordable Care Act has a number of provisions, including the Prevention Fund, other programs, including the Community Transformation Grant, and other interesting opportunities, including the CMMI, the Innovation Fund that CMS operates, that has the potential to direct more resources upstream to begin to tackle some of these challenges. And believe it or not, it does not take a revolution to solve these problems. More place-based investments can help to solve some of these challenges. Reducing residential segregation by expanding housing vouchers, allowing people to move out of distressed communities and into communities with higher opportunity structures. Enforcing anti-discrimination laws in home lending, real estate and rental markets. And encouraging investment, commercial business and housing development in distressed communities. And it's been encouraging to see community developers partnering with public health and other local and state agencies to begin to create incentives for greater business investment. We find that strategies to encourage public transportation, connecting people from communities with low job growth to areas with high job growth is also very promising. But there are other strategies that we know that work. Among them, and some of the most robust research evidence and data that we have to date suggests that investments in high-quality early childhood educational programs can have a very strong return on investment. A number of strong, controlled experimental designs, longitudinal studies following children into adulthood find that those children that were exposed to a high-quality early educational curriculum had better outcomes as adults, better educational outcomes, better vocational outcomes, less involvement in criminal justice systems, less dependence on public assistance, and lately, these studies find that they have better health as well as adults. We can also increase investments in communities in addressing environmental degradation through more aggressive regulation and land use decisions, structuring land use, for example, to reduce the concentration of fast food and other vendors selling unhealthy foods, creating incentives for grocery stores or other vendors selling healthy foods, fresh fruits and vegetables, to locate in so-called food deserts. And again, many of the funds that are authorized under the Affordable Care Act and other kinds of creative strategies can begin to direct these resources to these upstream problems. And many jurisdictions are using tools like health impact assessment to determine the potential health consequences of new policies and programs in areas outside of the health sector, such as housing, transportation, education, because they all have significant health consequences. Let me just conclude with a quote that I like from the World Health Organization from their Commission on the Social Determinants of Health, released in 2008. They wrote that inequalities in health and avoidable health inequalities arise because of circumstances in which people live, grow, work, and age, and the systems put in place to deal with illness. The conditions in which people live and die are in turn shaped by political, social, and economic forces. And I like this because it helps direct our attention that in many cases we have socially constructed opportunities for good health or poor health. When we begin to tackle some of these challenges, then we have another powerful lever to help reduce our healthcare costs and have a healthier population. Thank you.
Well, some terrific presentations and even more remarkable on time. So it leaves plenty of time for us. And I'm going to hog the first few minutes by asking a lead-off question to each of the presenters, although there's a lot to go on in those presentations. But, Bob, I couldn't help take up your challenge about healthcare spending is not a problem now because costs are growing only at the rate of per capita GDP. Isn't that due to the recession? And if so, don't we hope that that's a temporary phenomenon?
Well, in Medicare, the major reason why, at least the 10-year projection for costs, this isn't just a one-year snapshot, a 10-year projection that costs will be going up at about GDP. Now, that hasn't been changed for maybe a lower GDP, but we'll see about that. Is the specific $500 billion over 10 years payment reductions to hospitals and other providers. That's the dominant reason for those projections. In fact, those projections were established before this recent new news that volume isn't going up. It's sort of understandable that with the recession, that elective surgery and some other services where people are paying a fair amount out of pocket have moderated. But even in Medicare, where 90% of beneficiaries have supplemental insurance, the volume for Medicare beneficiaries has moderated. But the point I'm making here is that payment cuts can get you a long way. Most people say you can't just squeeze down on prices. And I agree with that. At some point you get diminishing returns, you get some perverse provider behavior if you squeeze too far on prices, but you can squeeze some on prices. And you can also go after abuse of, in terms of providing services that don't benefit people or that are frankly overtly fraudulent. And there are some areas within Medicare where that's going on.
So if the good news in Medicare is the result of lower reimbursements, what about the rest of us who are in the private sector? Are we shifting costs to private sector payers?
People argue about that. Economists argue about that largely. There's some cost shifting that happens when a hospital doesn't get has a negative Medicare margin, and nationally the Medicare margins are about 93-94% of costs are covered by Medicare. To some extent, probably, it varies over time. The hospitals then make up for that difference by raising prices to private payers, and in fact, on a national basis, hospitals get 40% higher rate for the same service than they get from Medicare. But the MedPAC analysis pretty much shows that the dominant thing that's happening here is that hospitals get higher prices from private payers as the initial action, are able to then have more sort of expansive administrative structures, have higher staff, lots of mid-level managers, and then are in a position to have negative Medicare margins, which they can tolerate because they've made up so much. So the question is, what's coming first? At least MedPAC's position is that because there's a whole bunch of hospitals who have positive Medicare margins, high quality, aren't able to get the same prices from private payers, that's probably the dominant thing that's happening, that there's probably some cost shifting, but it's probably not the dominant thing that's going on. So at least there is a view that Medicare can continue to put pressure on prices. What do private plans do? It's a good question, because left to just the market negotiating dynamics, the providers have the upper hand, and the question that I raised was, do we need some price regulation of some kind or some new form of market competition to try to address this problem?
But your price regulation would be across the entire delivery system, not just in Medicare? Well,
the model, I mean, in the 1970s, New York, New Jersey, Massachusetts, and Maryland had all-payer rate-setting programs in which they regulated prices to hospitals across all payers. It equalized Medicaid, Medicare, and private payers. Maryland still has the system. It's in place. It's generally worked quite well. It's got some problems. And so the question is, for those states, since we're thinking increasingly about state-based solutions, some states that might see a role for the government in doing that, it might make sense to do something like that.
So, Sarah, a couple of questions to you on measurement and transparency. One is kind of philosophical, which is the theory of this is that you put this information in front of individuals and they'll make appropriate choices. But we all know that doesn't really happen as much as we might like. So should people have the right to choose ineffective care, even if we can show them that it's not effective?
John, I think we have a long way to go to really translate all these metrics to consumers, which is actually why we think in the context of exchanges where you're really going to the individual market in a way that you really haven't, maybe you have a little bit on the Medicare side. But honestly, I think we don't think that people necessarily are going to be that interested in all the individual measures and getting into the gory detail, which is why we think this issue of creating these choice architectures is so important. And people their eyes tend to go to things that they see first. So even something as simple as just sorting the choices the first time people go to the screen with the high quality, lower cost plans at the top, I think could be very important in sending a signal that people don't even need to understand what the measures are. They can look at the stars, and as long as everybody feels that this is a good foundation for measurement, the experts, then the consumers can just go, if they trust the exchange and they trust the people who are helping them, then they can just use those signals that are set in the system without having to fully understand them in great detail.
Okay, but what I'm getting at is, should there be penalties for people who make bad choices?
One of the benefit designs I think that is very interesting is what's called value-based benefit design. And what it does is it does ask people who use a therapy that is less effective and more expensive than another to pay more. And if they use a therapy that is a high-value therapy, they can actually get care for free, which is a very strong signal. I think there's a lot of potential there. The problem is we don't quite have the evidence base to always point out to the care that is always more expensive, and so then you get into this kind of gray area. But there's some interesting work that's going on in Oregon where they are really trying this not only in Medicaid but in their employee health service. And they're being pretty brave about things like lower back pain and surgery and that sort of thing.
So I thought there was a tension between your approach and Brian's because it's great to be measuring quality, but suppose that quality is easy to achieve in certain communities and very difficult to achieve in others. Then what can we do with that?
You know, this is a philosophical question we always get asked about. We don't, for our HEDIS measures, we tend not to risk adjust them. And the thinking is, behind that, is that we really want to see what the measures are for the different populations that we measure by, Medicare, Medicaid, and commercial. And when we look at Medicaid measures, we do see lower performance. But we actually, when we look at them, we always see plans that are really good. And you don't want to hide that in a way by adjusting away for it. So my argument would say, yes, let's sample, let's stratify by the different populations, but let's see what all the data show. And you can understand that there are more challenges with certain populations, but let's at least see what the differences are so you can begin to address them.
So Brian, do you want to respond? Do you have any concerns about these measures being applied to lower income and minority communities?
No, I don't want to step into that controversy. But I think what Sarah said is right. I mean, when there are instances where systems are performing well for populations that have tremendous health challenges, you've got to figure out a way to encourage everyone to reach that high bar. At the same time, it's true, I hope, as my presentation has shown, that there are some populations that from early in the life course, they face systematic barriers to the opportunity for good health. So you're dealing with populations where kids, because of the experience of living in poverty or in a neighborhood with high levels of poverty, face a variety of health assaults. So we need to aspire to creating conditions where all can achieve their best opportunity for good health. But the reality is that many of these populations face significant challenges that health systems are only dealing with at very, very downstream levels and often years after those initial assaults.
Yeah. So Brian, I've been watching a little TV lately, the Republican presidential debates. And let me pretend to be one of those candidates and say, well, you know, these issues that you mentioned are really the responsibility of families. Well, child health, stuff like that. Besides, you know, if we do something now, it's not going to show up on the federal budget for, you know, a couple of generations. So why should we raise taxes on people now if it's not going to really result in any shorter-term savings? So what about the role of family, and how do you respond to people who say this should not be necessarily a government responsibility?
Well, history is so important here. Government created the conditions that we see resulting downstream now. So just to go back not that far ago, 60, 70 years ago, post-World War II, Federal Housing Authority authorized that there were GI loans that allowed people to purchase homes, and there was an explosion of home purchasing among returning GIs. But because covenants existed at local levels prohibiting religious minorities or families of color from purchasing homes in some of our newly emerging suburbs, we began to see the structures that allowed segregation to begin to take hold. So it took hold in many communities across the country. Obviously, segregation had persisted for many generations prior to that. The issue here is that all of our fates are intertwined. You can't gate communities off and expect that the health conditions that plague one community are not going to somehow also affect the conditions for health for others. We are all in that intertwined fabric, and we are so very much, our fates are dependent on each other. So it's in our enlightened self-interest to worry about every community and ensure that every community has an opportunity for good health.
I heard the president sound that theme the other night. One last question, though, for you, Brian. It seems to me that with some adverse trends in the middle class, we're seeing a hollowing out of the middle class. And what seems to be going on are highly educated, skilled people, regardless of race, are going to do very well and live in these very nice communities. And those who lack that education or in the service sector or whatever are going to be increasingly segregated by class, not necessarily by race. Would you like to comment at all on?
Yeah, absolutely. So we've seen real wages decline for the middle class. The kinds of jobs that people could at one time hold 30, 40 years ago, jobs with good benefits that didn't require high levels of education, those have declined. Many of them have gone overseas. The point here is that disproportionately, that population is a population of color. But that population is also growing in terms of the demographic changes in the country. So we clearly need to find ways to ensure that there are economic opportunities for every group. I agree with you that many of these are driven by class and education levels, but we have to attend to the fact that much of the inequity is driven by patterns like residential segregation. And so what we see is a worrying trend because we've not made as much progress in terms of ensuring that all of these communities have the same socioeconomic opportunities.
Okay, now it's time for you to get into this conversation. There's, I believe, 2 mics on the floor. And if you would go to the mic, identify yourself, and we'll just take turns going back and forth. So who wants to kick us off? Right here.
Chris O'Flynn. Bob Berenson mentioned that the rest of the world is somehow paying the medical service providers less than we are. And in terms of Brian's presentation, it reminded me of the World Bank data on life expectancies published on their website, in which the United States ranks last behind all the G7 countries. In fact, it's quite down on the list, whether you measure from birth or age 50. So, however, the rest of the world doesn't all use the same system for providing health care. So my question to the panel is, what is it that the rest of the world is doing with their various systems that they have in common that we're not doing that enable them to get lower cost and perhaps better quality?
In 1 minute or less, please.
Well, I mean, the first thing I want to say is that there are lots of variations in sort of some notion that there's this uniform socialist health system over there somewhere. They are all different. The National Health Service in the UK is a model for the UK. Sweden has a National Health Service of sorts, but Germany doesn't. France doesn't. They've got social insurance systems with private insurers and providers in the private sector who are not government employees. It is an interesting question. What is the common thing across them all? I think if I had to pick one, I would say that it's probably a larger role for government as at least a regulator of what's going on. In most countries, not a provider, but as a regulator of what's going on. Some countries actually, like the Netherlands, like Switzerland, like Israel, are actually promoting competition amongst private insurers. They've actually moved from not-for-profit sickness funds to for-profit insurers. But they all are within a sort of regulatory structure so that there's some bounds on how it functions. So I guess that would be my simple answer.
Yes, Sarah?
I think this isn't a quality topic, or maybe it is, but I think also I've heard that it is really, our system of medical education is really unusual, in that we're expecting private support for education. That we don't have anything like that in Europe, where people come out of medical school and they don't have a giant amount of debt to pay down.
Mm-hmm. Yes.
Yeah, I was wondering about the overutilization, and I assume that includes, individual choice as well as physician choices in hospitals. But I was also wondering about more geographically based or regional issues. So for example, in some cities like Boston, every single hospital has a really expensive MRI machine, and they do it because they want to be a full-service hospital and so on. But it's not needed in terms of the population. So I'm wondering whether Medicaid or Medicare has any capacity to negotiate things like that, which does lead to overutilization. And then on the other hand, in some low-income places, like say Rosebud, South Dakota, an MRI machine is not anywhere within hundreds of miles. They don't even have a bank, much less an MRI machine. So wondering, is there any way, given that we have lost all of our public hospitals and institutions, and healthcare centers even are not well distributed, is there any way for this type of body to intervene in that to make healthcare more accessible?
Bob, it seems like we've been down this road.
This body, meaning the Nasi?
No, just thinking of, in thinking about Medicare and Medicaid, are there ways in which those programs...
Again, these are very great questions, but defy a 20-second answer. What I sort of resonated to was that you've made the case for why we need to move away from fee-for-service, volume-based reimbursement, which has spawned what some economists call a medical arms race, by which they mean competition is not over price and quality, but basically over who's got the latest and greatest of high tech. And so it is non-price competition, which is going on in many communities. So it's not just the Boston hospitals that want an MRI. There are now, I heard a presentation from an 11-member cardiology practice who have its own MRI machine and PET scanner. And was sort of the administrator of this practice was sort of put out that Medicare actually might want to change the payment amounts to try to discourage an 11-member cardiology group from having that kind of abuse of technology. So basically the idea is that over 5 to 10 years we would develop new payment models and new organizational models where providing unnecessary imaging services would no longer be a moneymaker to an organization, but actually would be viewed as a cost center rather than a profit center. There's a lot of resistance to that kind of a change. It changes the business model for many institutions, and that's why I think it will take a while and how we have to figure out what the carrots are as well as the sticks to encourage organizations to make that move so that they use an MRI machine appropriately, that there's enough scale of the patient population so that it is not in the interest of an 11-member cardiology group to bring that kind of technology in.
This problem was the origin of the Certificate of Need program, and I think anyone who believes that government can say no should study the history of that program. Yeah, right here.
Wow.
My name is David Reamer. I'm with a group in Milwaukee called the Community Advocates Public Policy Institute, and we have a project on health insurance exchange education. I'm also on the Nasi panel on exchanges, but I'm not speaking for them. This is really a question primarily for Sarah, to some extent for Robert. It deals with the issue of how you get people and money into what you described, Sarah, as the Northwest quadrant, the part of the healthcare delivery system where costs are low and quality is high. Massachusetts clearly hasn't done it through its connector. A lot of questions about whether the federal exchange can do that. But there's one model that's actually worked to do this. In the state where I'm from, in Wisconsin, the state employee health plan, which buys on behalf of about 80,000 employees, basically invites people to choose either a Tier 1 plan, which is the Northwest quadrant, low cost, high quality, or they can go to Tier 2, which is either higher cost, good quality, or the opposite. or they can go to a fee-for-service, which is what you might call the southwest quadrant or the southeast quadrant. It's high cost, low quality. And they can choose either one and any plan within each. But if they pick a tier 1 plan, they pay a lot less. If they pick a plan in the other quadrants, they pay a lot more. What we've learned was that in the one county where the people in this exchange represent about 25% of the population outside of Medicaid or Medicare, dramatic reductions in premiums. Everywhere else, no impact. So what we've learned is that if you have an exchange that's large as a percent of the population and has average risk, and everyone has an incentive to go to the northwest quadrant, and you have available competitors that, whether they're ACOs or not, they're integrated delivery systems and so forth, you get $3,000 less annual coverage, no other factor explaining it. Wow. So the question is, we actually do have a model for how to hold down costs, but I'm not seeing much discussion at either the state or the national level about taking the one successful model for making exchanges work to lower cost and improve quality and taking it wider. Why not? What's the reason why we're not doing it?
I think there are actually some Medicaid models that do something similar, which is they take the plans, they don't have a lot of signals through the premium, but what they do is there's a large number of Medicaid folks who don't choose, and they will auto-assign people to the high-quality plans, so that rewards the plans for high quality. So there are other models, and what I would love to see is a much larger national discussion of some of these successful models and how they could be experimented with in some of the exchanges where there's an appetite for value purchasing. Mm-hmm. And I don't think everybody's going to want to do this. But I think that there are success stories, and it's not rocket science because people have figured out how to do it already. I would love to see that. I think that there will need to be some kind of waiver authority or something, because right now the way the system is set up with the subsidies go to the lowest bidder, and there's no variation of the subsidies based on quality. I'd love to see some ability for the CMMI to include maybe another initial there with exchanges. To actually allow for some experimentation where there's states that are doing this.
Yeah. Last question back here.
Hi, I'm Ellen Bruce from UMass Boston, and I have actually two questions for the two parts of the panel. The first one is, why do you think that accountable care organizations will have more success in acceptance and a variety of other things than the other managed care kinds of things that we've gone and experimented with for the last 15 years? Mm-hmm. And then my second question is really for Brian, and that is, are you making an ethical argument or an economic argument? And whether, well, let me just say, obviously the ethical argument is there, but do you think there's an economic argument that stands on its own?
Great.
Thank you. To go first. I'll start with the accountable care organization. I mean, I think that, as I emphasized, I think we have a ways to go before we figure out how to do accountable care organizations, figure out the proper payment model that encourages lower cost care but doesn't result in stinting on care, which I think was one of the Achilles heels, at least as perceived in the 90s, the perception that providers, physicians were being given incentives to not provide care. So that's where the role of quality measures come in, and how robust those quality measures are going to be to try to assure the public that the physicians and others aren't taking the money and not providing the care. I think it's going to take us a while to work through that. The basic reason why it might work and why I'm glad that we are starting this experiment is that it embeds the new payment model, the new organizational structure, and ideally a new culture of care right with frontline clinicians, not just with a managed care organization and an insurer who has a role to play but is one step removed from the actual delivery of care. And so I think that is the notion that, I mean, an insurer who is still paying fee-for-service to physicians who have an incentive to generate lots of MRI services is a step removed from the decision-making. And so the goal is to try to get that decision-making, try to change the incentives in the organization at the level of decision-makers. We have some positive experience in California where virtually half the insurance goes through HMOs that then pay medical groups based on capitation, a fixed amount. And they're beginning to come up with pretty good results on quality and cost. So this is not just a guess.
Thanks.
Sure. Just quickly. So yes, I'm trying to advance both an economic and a moral argument. Unfortunately, the moral argument, there's less space for that debate today. So we focus on the economic argument. And I'm sad to say that. But the economic argument is a simple one. The demographics of the population are changing rapidly. We have a growing population at risk for poorer health. Intervening on the front end saves us money on the back end. So.
I had one point on the ACO. As envisioned, at least in Medicare, there's no lock-in. So there's a difference there, too, that I guess if the beneficiary is willing to change their providers, then they're not locked into the ACO.
Let me go back to Brian for a second, because I do think one of the challenges politically is that the prevention fund is the weakest part of the ACO politically. It's being targeted to be defunded or the money reprogrammed. And so I guess I'm questioning whether the economic argument is sufficient. Because, again, CBO is not going to score a lot of these things within a 10-year window.
That's right. And there's been a huge push to try to get a change in CBO scoring for this very issue that we know, and again, there more research needs to be done here, but the suggestion from the research that we have to date is that there are significant savings to be realized at the back end with modest investments at the front end.
Okay, time for one quick last question.
Just to pick up quickly, really, on the proof of concept question with regard to ACO. So Bob just mentioned at the end of his last comment in California, if based around Kaiser, but really, but with other examples too. There are some examples of the same basic model, not exactly the terms of the federal ACO. There is a lock-in in Massachusetts as of the new contract negotiated last week. 70% of the two largest insurers' plans are now global payment. Yeah. And if you look at some examples, some nonprofit Medicare Advantage plans have been using the ACO model consistently for the last 15, 17 years. And the data is positive in terms of both quality and cost. You have to remember on ACOs that has to do with can have to do with quality. It can have to do with utilization. You still have to deal with the base unit cost that you're paying per member.
Okay. So I'm going to close this by leaving you with 3 takeaway messages. Okay. So number one, healthcare is really expensive, and it's going to get a lot more expensive. And we've got a pretty urgent situation in front of us, even if Medicare is growing more slowly, just because of the dynamics of the federal budget. Number two, this is complicated stuff. We're getting into a very much more complex environment for healthcare with lots of different initiatives, lots of different language terms. So that leads to number 3, how are we going to get the public to understand this stuff so that they can behave in a more appropriate way? Because after all, we're trying to serve them better. So I think that's a huge challenge that we haven't even talked about. We're now going to take a break, and we're going to come back and talk about the immediate challenges of implementing the Affordable Care Act at 3 o'clock. Thank you very much, and thank our panel.